So this is a right revision tympanoplasty. This patient was operated 3 times by our surgeons, and I don't know exactly what has been done because I don't have the previous file. What I know, if I look here, is that we have this cartilage grafting here, and no sign of ossicular reconstruction, so I don't know exactly what has been done. So I will elevate, do the midday exploration. So this is 12 o'clock, 3 o'clock, 6 and 9, and we have those 2 exostoses reducing the size of the ear canal. Although it will be more posterior, the exploration, I think I need to drill out these 2 exostoses. So I will do a large incision like this all around. I will not elevate, of course, the whole flap, but I need to elevate partially the anterior part to expose the 2 exostoses in order to do a canalplasty first. Okay? Then I will go back posterior in order to explore the middle ear. Peut-être un plus petit là, parce que la peau est... Oui. Il faudra une lame de silastique. Hein. On est à combien en tension là? Comment? Okay. So it's bleeding a little bit because the blood pressure is increasing, so we're going to control that. Okay, I think for this one is fine. I need to expose a little bit more the left one. Okay. So I put a silastic sheet here to protect the skin, and I will start by the right exostosis first. Ok, après s'il vous plaît. Vous n'avez pas plus petit que ça? Oh mais ça va aller en fait. Là, je vais prendre un plus gros peut-être. Bonjour. Oui, merci. Okay, fine. I will do the right. Les ciseaux à frapper, s'il vous plaît. Bon, donnez-moi encore la fraise alors. So you know my technique, I try to make a groove first and then try to use the chisels to finalize the resection. Allez-y. Oui. Okay, it helps a lot, I think, by doing this. Pince. Okay, let me see if it's better now. It looks better. I need to enlarge a little bit more, I think. Le décolleur encore, s'il vous plaît. Yeah, I need to drill out this part again, a little bit more. And then I think it will be fine. La fraise encore. Quite a huge exostosis, eh? You see more than what we thought. You know, I'm always thinking in terms of exposure, and I think if I did not do this, I would have in trouble to expose more in a nice way the middle ear cleft. Yeah. Okay, let's see how it goes there. I think it's fine, and now we go to the left. Calmez s'il vous plaît. And I need to drill out the left one. Yeah, this one. La fraise, s'il vous plaît. Very hard bone. Calmez, s'il vous plaît, encore. La fraise encore. very strong bone, very hard. Ok, là, les ciseaux frappés s'il vous plaît. Allez-y. Oui, 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 oui. Ok, pince. Décolleur. Okay, I think I need to drill out a little bit more to the left and then it will be okay, and I will come back posterior then after that. La fraise s'il vous plaît. Ok, voilà, je vous rends la lame. Ok, let's see. I think it's much better now. Calmez s'il vous plaît. And the skin is not so good, but that's all I can do. It's just there we go. Okay, now it's much better. You see that? Now we have a much better view of the entire, not the entire, but at least the posterior half of the tympanic membrane, which is good enough for me. And I will put a silastic sheet in the middle because the skin is really bad. So I want to find my cleavage plane later on. Ok, allez, la lame de silastique s'il vous plaît. Alright, now I can go into the middle ear. So I will elevate the posterior half of the flap now and enter allowing for me to enter the middle ear cleft. Décolleur. Still quite narrow, but better than before. Encore décolleur. Ok. Alors, calmez. You see the prosthesis there, I think. Some titanium prosthesis head. So I guess maybe there is no more malleus. But I saw it in on the CT scan, so okay, so I want to dissect this prosthesis now first. I want to dissect you can see the cartilage interposition because that was the choice was made for titanium prosthesis. Of course, the previous surgeon was using a cartilage interposition. Décolleur encore. And the thing is that it seems that there is the malleus. I think it is, and strange choice that some surgeons, although the malleus is there, sometimes they don't want to use it and they just put the prosthesis underneath the tympanic membrane. But I think the stability is not that good if you do not attach the prosthesis to the malleus when the malleus is there. Calmez, s'il vous plaît. So you see this exostosis running into the middle ears. Very strange. But of course I'm not going to remove that. Canalplasty. This process I think is a little bit short and not, you see the tilting that we have here. It's not working because it's loose, I think. Canalplasty. So what I'm doing now, I'm trying to dissect this prosthesis in order to remove it. It's completely dislocated, so I can remove it now, okay? And now I need to check what kind of residual ossicular chain we have, mainly in terms of a window, if we have a stapes or not, and if we have the malleus. I think the malleus should be there. I think I can feel it. Alright, I'm going to check that first, and I will check the over window later. Alors, calmez, mangez marteau. We have some stapes, some residual stapes. Now this is the cartilage here. Too thick, in my opinion. But of course I can't remove it, so I have to deal with this. And you can see the malleus handle here. So this was not used. And again, I don't understand why. They just put this prosthesis underneath the tympanic membrane. And we lose 1 point of stability by doing this, I think. CISO. But of course that's personal choice. I always try to use the malleus when the malleus is there. So I remove a little bit of cartilage. And of course I'm going to use a hydroxyl tight head prosthesis, which means that we don't need cartilage in the position. So I could even remove it, but I don't want to do it because it's too much connected to the tympanic membrane, and if I try to remove it, this will create some perforation. So I will keep it. The only thing I try is to be able to dissect the malleus handle in order to relocate the malleus posteriorly, because you can see now we have a really anterior malleus. This is the short process. And it really goes really anterior. So I have to go anterior to the malleus with the needle, following the bone. And of course I will have to check the tympanic membrane. Maybe we have a tear because it's very close to the... But I will check it later. You see the umbo here? Which I think is already dissected. There's some residual attachment there. Okay, good. Alright, lancez-vous les direct. So now I'm going to cut the tensor tympani tendon. And then I will try now to relocate the malleus posteriorly. And then I will check the oval window. There we go. Now you see the new position. Now we have this residual. Sorry?
The position is not looking very stable.
Yeah, but with the prosthesis it will be fine. Because they both together will be connected. You see what I mean?
Yes.
And this is something which I would like to remove, but I don't think I can. So anyway, I'll try to. Crochet, s'il vous plaît. Okay, so I will place the malleus over there, like this, okay? And now I'm going to check the foot plate, because I think there is a partially eroded stapes and neuf, s'il vous plaît. So what I will do now, I will try to check the foot plate to see if it's mobile or not. This prosthesis was a partial prosthesis, but you can see that I don't think I can use the stapes head here. But the stapes is mobile, eh? You see that. If I move the, you see it's completely mobile. Measurer. Alright, so I'm going to measure now the distance from malleus to foot plate, because of course I will use a torp. Which is 5.6, so it's going to be a 6.5 millimeter long prosthesis. I was at 0.5. Okay, let me see how it goes with the tympanic membrane. I need to check that. Then I will check the stapes. If I can, just question if I can use the silastic banding technique or not, depending on the status of the stapes itself. You can see that the drum is fine. So this is quite good. Redonnez-moi une lame de silaxique s'il vous plaît. Ah non, ça va aller. Voilà. Ça va, je pensais qu'elle était un peu courte, mais c'est bon. Je vais la replacer là. Okay. Alright, so now I will check the stapes. Okay, so table vers moi. Stop. I need to see if I can place the band, so I need to dissect a little bit the stapes head to see if it seems to me that there is a stapes tendon there, and there's a lot of fibrous tissue surrounding the stapes head. C'est un 9 que j'ai là? Faut un 9. Correct. Alors attendez, donnez-moi un 15 du coup, alors je vais m'agrandir un peu là. I will do a bone member section here, because I just want to see the stapes tendon, and the exposure is not that good. J'aurais peut-être besoin d'un 20 maintenant, hein, même. You see, I like to enlarge more.
Yeah.
You see the facial nerve on the left, so it's clear, but I want to see if I can, at least the stapes tendon, and if possible, the pyramidal process. You see the tendon coming more and more. So by relocating the malleus, I recreate one point of stability with the malleus. And if I could create another one with the stapes, that would be really, really great. Otherwise, I will put a torp like this without attachment to the stapes. Okay, good. Let me see how it goes now with the stapes itself. Trois de choc, s'il vous plaît. Un œuf. So the stapes tendon is there, but too much fibrous tissue. Yeah, stapes is there, but there's an eroded stapes head, so I don't think I can use the band. Because this is, stapes is there, yeah. I can try. I will cut the tendon at that level. Okay, ciseaux s'il vous plaît. So closer to the stapes than usual. Ok, 3 de chouk. Bon, on va choisir une prothèse totale, hein, s'il vous plaît. Okay, that's fine. Now you see we have now a clear exposure of the stapes. And now we're going to put the prosthesis. Plafond, s'il vous plaît. Ok. Un 9 encore, s'il vous plaît, d'abord. Ou un 12 si vous l'avez, c'est pas grave. C'est un quoi ça? Crochet à os. Un 9 maintenant, à nouveau. Poser la platine. Okay, I will remove the blood and then we'll put the prosthesis. All right. Okay. Okay, s'il vous plaît. So we said 6.5, because I measured 6. So I always add 0.5. So to get 6.5, I need to go first to 5.5, okay? And then pull it back to 6.5 because the proximal part of the shaft goes through the prosthesis head, okay? All right, that's fine. And now I should be able to pull it back. Do you see 5.5 at the moment? And now 6.5, okay?
Yes.
All right. I think I need to push the band a little bit more. Donnez-moi une passe, s'il vous plaît. Okay, let's see. C'est un 12, ça. All right, first, I don't care about the band. I will just insert the prosthesis and try to place the distal tip in contact to the foot plate. Calmez, s'il vous plaît. So I think I will have to push the malleus anteriorly. I have to go here. doesn't want to go like this, so I need to change. I need to help with the needle like this. Okay, that's fine now. All right. Okay, now I will rotate and try to insert the malleus within the groove. I need to rotate that, but the problem is that I have this residual mucosa underneath the malleus handle, and you see I have some trouble to rotate the head. That was, I wanted to cut it, but I couldn't remove it. That's the problem. So maybe I need to go to the other side. Yeah, this mucosa is a problem, but now it's better. And you see it fits well, but it's not connected to the footplate, so it's not good. So I need to work more with the prosthesis. It's tricky because I need to place the distal tip of the shaft to the footplate, which is not the case here. Might be a little bit too long, I don't know. I will check that. So it's tricky to determine the length. The shaft is moved posteriorly, you see that? Mince, je vais essayer de la retirer. So I need to remove it, but it's not so easy. Fixed. Canalplasty. So we need to work to remove this shaft, which was moving to posteriorly, and now it's difficult to remove it. Huh. There we go. Okay, now it's better. But again, I have this mucosa, which is creating some problem. The shaft is good, the head is not good. You see that? It's bending like this. So I have to try again from the other side. Terrible problem. I don't know how to get this mucosa out of the field, but it's difficult. Donnez-moi le lancer direct. It's a thick one. It's not only mucosa, but it's really thick, as you can see. Donnez-moi la pince, s'il vous plaît. Cannot even reach it with the needle. There we go. Calmez, s'il vous plaît. And all the problem is also related to the cartilage interposition which was made, which is also pushing the malleus posteriorly. So now I think it's not bad. Let me see, it works fine, I think. You see how it goes? So it's fine, and the malleus is there. I need now try to attach the prosthesis to the staples with the band if I can. Not sure I can do it, but I will try. Alors, le 3 de chouk et un 12, s'il vous plaît. Because if I attach it to the stapes, it will help for stabilizing the prosthesis on a vertical plane. So of course this will dislocate partially, temporarily the prosthesis, but I don't care. It should go underneath this part, and that's the problem, huh? It's a tricky time here. Yeah. Nearly done. Nearly. There we go, but it's not perfect. Okay, I don't think I can place it better than this. We have this part which should be underneath the tendon here. There we go. This is underneath the tendon. And I saw that there's a hook here which is better now. You can see now it's fine. And if we move it, it's working fine. Okay? Yeah, like a single unit. Okay, I think now there's a better chance of stability. So I will reposition the flap and see how it goes in terms of prosthesis length, which might be a little bit long. I don't know. Because I can see that the prosthesis moved posteriorly, which is not a good sign. You see? Dislocated. So this means that the probably a little bit too long. I don't know. No, it's not. This is good, in fact. This position is very nice, but the problem is the flap. I may need to put some perichondrium to reinforce the skin, pushing the skin a little bit lower like this. It's the best I can do. You see, it's dislocated, still dislocated. I don't know why it's moving like this. Even if I don't use the malleus. Of course, this would be the perfect position. But then, if I keep it like this, then I have to do a perichondrium graft. Je crois qu'il va falloir que je prenne un périchondre. Because you know, there's a lack of skin there. And then I need to reinforce that. But now it's much better, much more stable. Okay, let's take a perichondrium just to reinforce the skin there. Allez, on va prendre un périchondre. Yeah, everything's fine. Okay, I just need to reinforce the skin, so we're going to stop the recording for just the time for taking the graft. Okay, so this is the perichondrium graft, which I took from the concha, because there was already no more perichondrium or cartilage at the level of the tragus. So again, it's still bleeding a lot, but that's the best I could do. And now all I want to do is to reinforce the skin posteriorly like this. Ça saigne toujours pareil, hein, c'est pas changé. Bon, allez, ça va. Okay, I think it's gonna be fine now. But you see the very poor quality of the skin of the flap. It's very, even when you suck, everything goes out. So it's very bad. Okay, now it's fine. Okay, you see the anterior angle now? And now the skin, which is protected and reinforced. And this is fine. Donnez-moi une lame de silastique, s'il vous plaît. Okay, looks good. I think all is there. The skin is back to its original position. I will protect the graft here with silastic sheet. And then I'll put a mirror cell. Alright, complex case, but interesting. Allez-y. Okay, I think it was interesting. Good case.